welcome back to EX. I'm Alice. I'm here with CTSNet, and I'm going to be speaking to Prof. Jorge Mascaro. He's a cardiac surgeon. So if you'd like to introduce yourself and a little bit about where you work and what your fields of interest are.
Hi, Alice. Thank you very much. Pleasure to be here. I am a cardiac surgeon. Used to be working for many years in the UK, in Birmingham, and now I have transferred to Wisconsin, to the Medical College of Wisconsin. That's where I am at the moment.
Great. And what are your fields of interest that you particularly like?
Well, in general, cardiac surgery has always been my passion, but within it, I will say that transplantation, heart, lung transplantation, and aortic surgery, later developed in life, but became one of my biggest passions actually, and until now involved in that.
Great. And I know that you were the first surgeon to put the thoracoflow in the UK.
Yeah.
And so I thought we'd talk a little bit about type B dissections, because I know it's quite a hot topic at the moment in aortic surgery, and especially, if we're thinking about our trainees who might not get lots of experience to it and knowledge of it at medical school. I thought we could talk through that. So what is a type B dissection?
I think, first as definition of type B dissection is any dissection of the aorta that extends beyond the left subclavian in distal. There are people with type A dissections whose aortic dissection doesn't stop in the ascending aorta; it extends into the aortic arch and then beyond the left subclavian. All of those patients, they have a type B dissection, or any dissection that either originates at the level of the left subclavian or that extends beyond the left subclavian, including the aortic arch, will have a type B dissection. It needs to be addressed as a type B dissection.
And traditionally, what would our management of these type B dissections be, and how do we determine what we do for our patients?
Yeah, interesting question. If it is a pure type B dissection, the standard of management has been medical treatment. And it is medical treatment. When I say medical treatment, is to control the blood pressure, control the pain of the patient, and make sure that the dissection doesn't progress, and that the aneurysmal development of the dissection doesn't happen. So it's mainly medical treatment. However, having said that, and now more recently, and I have to say that I'm very pleased that the most recent guidelines in the management of aortic diseases is treating the aorta as an organ, not anymore as an artery, and is an organ. So the approach to any dissection is now more holistic. And specifically in type B dissections, there are lots of changes coming in. And one of those is the early treatment of type B dissection, not by surgical intervention, but by the use of endovascular approaches.
And why are we beginning to, think that's a better way of treating it?
First of all, we know that those patients that suffer of type B dissections, many of them, they have connective tissue disorders. And in those patients, it's very likely that the aorta is going to develop aneurysmal transformation. So the aorta is going to dilate and is going to need, in the future, some sort of treatment. Now, in the future means an elderly patient as well. So if we can treat and we can prevent that of happening, what we're trying to do these days is to bring all of that forward and treat younger patients rather than elderly patients.
So they have better outcomes.
Better outcomes and in better conditions. And the other thing is that we are trying to prevent malperfusion syndromes. Many of these patients with, not all of them, but many of the patients with type B dissections, they develop malperfusion of the legs or malperfusion of the viscera. And that's what we're trying to prevent.
At this conference, there's obviously a lot of, new ideas being shared. Is there any particular talks to do with, dissections or aortic surgery that you've attended that you think is important?
I think, as mentioned before, the aorta now, everyone is really enthusiastic about this treatment of the aorta as an organ. in trying to address many areas of the aorta at once with just one treatment is something that is everyone is trying to promote. In type A dissections, for example, the use of the frozen trunk for acute type A aortic dissection is something that is increasingly more accepted as a standard of care. Although there is no randomized trials available to my knowledge, the evidence is showing progressively that treating the type A dissection with the treatment of the aortic arch and the proximal descending aorta is something that is beneficial for patients for the future.
So thinking about your patient long term rather than just in that immediate management.
Exactly.
This is where our field is now turning towards, because we can see the benefits.
Exactly.
And one final question. So I know in the UK there's, we're talking about whether we should have fewer, larger centres that are experienced in dealing with the aorta rather than sort of lots of centres with minimal exposure, because obviously these patients don't come through our doors every day.
Yeah.
What are your opinions on that?
I think that's very, very interesting. It's a very interesting question because it makes patients with aortic dissections, either type A or type B aortic dissections, to go to centers of excellence. It may be that there is not that many centers of excellence. And when you face a surgical emergency, the patient, what he needs is his or her life to be saved. So it does pose a challenge. But if we're talking about all these more complex operations, they shouldn't be performed in centers that don't have the experience. So that brings us back to the centers of excellence. So I think, yes, there should be centers of excellence. The outcomes are much better in centers of excellence that centers that do a handful of these aortic dissections, for example, but there need to be more. It can't be that it's only 3, 4, or 5 centers, because the pathology is much more common than what we think. So it should be more.
Great. It's been a pleasure speaking to you. Thank you so much. And enjoy the rest of the conference.
Thank you. I will.